Hello and welcome everybody to this seminar about approaching the patient with CKD and comorbidities associated and how to choose the right treatment. So today it's my pleasure to present Professor Luiza Caramori. She is an endocrinologist and she's working actually in Cleveland Clinic, and she's also professor in medicine in the University of Minnesota. Thank you, Professor, for being here today with us.
My pleasure. Thanks for having me.
And we can introduce as well to Professor Rafael de la Espriella. He's a cardiologist, well known in Spain for his cardiorenal unit, and he's working in Valencia in Clinical Hospital of Valencia. Welcome, Professor de la Espriella.
Hi, thank you for having me.
And we hope that we can join Professor Jolanta Malyszko, but she has had some experiences, some problems. So we are going to start without her, and we hope she can join us during the session. So the first thing I'd like to know is about some questions to discuss with you today and some others that can arise during the presentation. So the first questions for the discussion is about the right approach from a cardiology, endocrinology, or nephrology perspective. And I would like to start with Professor Caramori. Luiza, what's your perspective for a patient with hypertension, with obesity, with diabetes, and chronic kidney disease, as this is a very, very complex patient? So what's your first approach?
Yeah, so what's the first approach? I think that's a difficult question to answer, right? I think that our goal in general is to improve quality of life and expand the lifespan of these patients without causing any problems and avoiding complications for them. So when we have a patient this complex, we need to delineate one strategic plan that will work on many of the conditions that they have. We usually start by addressing lifestyle modifications because that I think that's foundation for a lot of what we do. We talk about a health diet, and that sometimes includes weight loss, right? If the person is overweight or obese, so we certainly discuss a health diet. We talk about exercise. We talk about quit smoking. We don't have a large proportion of patients who are smoker, but in other areas of the world, the people still smoke significantly. So that's an important discussion to have as well. And then after we cover this basis of the foundation, then we start talking about managing of blood pressure, what the goals are, and what are the drugs that we can use that having a proven beneficial effect both from the cardiovascular as from the renal perspective for these patients. Then we talk about glucose management if the patient has diabetes, right? Again, which agents can we use to facilitate glucose management on top of what we discussed before, exercise, diet, and a health lifestyle, but also which agents can we use that are going to provide them with this additional benefit that goes beyond blood sugar control. So I think that the conversation has changed a lot in the past several years, going from kind of like a glucocentric view when we have a patient with diabetes, we want to control blood sugar, to what else can we do to protect this patient's heart, protect their kidney, giving them a better quality of life. So we usually start with those discussions, and it depends on what the patients bring to you. I often ask them, what's the main thing that you want to address? Because we have so many options and so many different medications that we probably want to put these people on. And then we are going to have a separate discussion about should we do all together or not. But I think that there is a lot. So I think that if we start by addressing the things that are more important to the patient, I think that we get this buy-in and allow us then to work over time with the patients to achieve all these goals that are much broader than simply controlling blood pressure, blood sugar, and having them in a health weight.
That's a very nice thing, because we've been like separate things, like cardiologists from our perspective, nephrologists from our perspective, endocrinologists from our perspective. Every one of us had different points and different glucose or creatinine syndrome or whatever. So what's your perspective, Rafael?
Yes, absolutely. I think we all know for many years now the comorbid relationship between diabetes, obesity, and cardiovascular disease. However, despite there has been a paucity of efforts to identify those patients who are especially at risk, we all maybe just looking at the patient from different perspectives, from the endocrinologist's point of view, from the cardiologist's point of view, and maybe we forget that the patient with cardiorenal-metabolic risk has a stepwise progression from at risk until disease, established disease. So I think the job that we have to do with these patients is try to see the whole thing, the whole picture of the problem, and start to address all the interrelated comorbidities and also the interrelated pathophysiology of the problem, and start to treat these patients in this manner in order to get to the reduced burden of comorbidities and morbidity and mortality of these patients. Absolutely.
So it's my pleasure to present Professor Malyszko. Hi, Jolanta. How's things? And thank you for joining us today.
Hello.
And she's from Poland, from Warsaw. She's working actually in Warsaw. And I would like to know, what about nephrologists? What about our perspective? We've been like creatinine centrum as well, but now we are totally different, and things have changed a lot, and we are interactive, and we interact a lot with other specialties. So I would love to know, what's your opinion about the goals of treatment on hypertension, on obesity, and diabetes and chronic kidney disease?
Dear Fernandez, thanks a lot. From nephrologist perspective, first of all, several years ago, we were considered as dialysis doctors. So it was mainly like that. And now, with all advances in new world concerning the new therapies, we think that we are, well, I cannot say more nephrologists than before, but we try to put everything in the perspective of the holistic approach to the patient. So this is the matter of, I cannot say the multidisciplinary team, because generally majority of us are based on internal medicine, plus doing subspecialty like cardiology, endocrinology, diabetology, and nephrology. So that's why we have a very good background to look at the patient as a whole. Not only from the, I would say, the glomerulocentric point of view, or nephrocentric point of view, or creatine point of view, but mainly as the kidney failure is price we are paying for our civilization. Because it's the price to pay that cardiologists are so good and they are treating our patients so well, they are saving lives, but the price for that is impaired of kidney function. After acute MI, or after long-term hypertension, or after long-term heart failure, in generally, there is a kidney problem. Because heart is an extremely good pump, which pumps, let's say 20-25% of the blood to the kidneys. So when the heart is a little bit worse, that's why kidney are working not so working suboptimally. So this is one point. The second one, the diabetes. There is a problem also of the civilization of our developed world, type 2 diabetes, and there is also a price we are paying for the long-term diabetes, because, well, even at the moment of the diagnosis, 50% of our patients have other complications. This is a macroangiopathy and microangiopathy. So right now, our perspective is that with the new drugs, I mean mainly SGLT2 on board, and also non-steroidal mineralocorticoid receptor antagonists, we are on much better or safer side, because previously in the last century, we have our RAS blockade. And after many years of RAS blockade, which was considered nephroprotective and cardioprotective, we have much more in the armamentarium. course, I mean, the easiest way is just to take a pill. But there is another one side. I cannot say that it's a much tougher side, like getting off our habits, our bad habits, like smoking or losing weight or physical activity. It's much more difficult to achieve, or it's much more difficult to do something like that. It's much easier from the patient's perspective. That's what they want, 2 or 3 pills. And patients are thinking, and we are thinking as well when we are patients, that it will solve all of my problems. No, it's not the problem of the pill. It's also the problem of my attitude towards my health problems. What can I do for myself? If I can stick to a new diet, if I can restrict like smoking cigarettes, if I can enhance my physical activity and make my positive relation to my life, this is one point. And the second one is a pharmacotherapy. So now it's a combination, not only the RAS blockade as the first pillar, but we're putting like following cardiologists, the second pillar with SGLT2 inhibitors, and the third one with non-steroidal MRAs, hoping to get rid of this residual risk and try and working for the better outcome. And first of all, I would say for nephrologists that the best possible way is to delay dialysis as much as possible. Because, well, only the lucky people, they can survive to the renal replacement therapy, because vast majority of our patients are dying because of cardiovascular problems before reaching end-stage kidney failure. And this is the moment when we should try as hard as possible to put nephroprotection with a cardioprotection to delay progression of chronic kidney disease and not to reach end stage.
So thank you, and asking about this challenges or this pharmacotherapy, what's the role? Jolanta has already talked about the role of pharmacotherapy. I'm going to put that here. What's the role of pharmacotherapy, SGLT2 inhibitors, GLP-1 receptors, non-steroidal mineral receptor antagonists, and in this kind of patients with comorbidities? So do we use these drugs? Do we all use these drugs? And something quite interesting for the nephrology community right now is about, on the light of all current evidences, do we start all drugs at the same time? And I said that because nephrologists always been like, okay, let's start with this, a little bit of this, and then we will add a little bit of that just in case, and then we will add a little bit of this one, and we'll mix. And there's something totally different from cardiologist perspective, because they use drugs like all from the beginning or not, I don't even know. So I would love to start with Professor de la Espriella, with Rafael, talking about that. Do you believe in sequential treatment, or do you believe that everything must be done from the beginning?
Yes. Let's see. I think that's a difficult question and depends on the patient and what's the risk of the initial risk. We all know that this kind of drugs, all of them works or have an influence in the hemodynamics, in the glomerular hemodynamics. So if the patient has already have a reduced GFR, or is vulnerable to these alterations, maybe when you start these treatments and you see a drop in the GFR, maybe you make step the brake and slow down the treatment titration or initiation because of fear of side effects, renal side effects of the drugs. However, the 2021 European guidelines of heart failure, for example, give a strong recommendation on to start these treatments in patients with a GFR above 30. So despite of that, we all know that this is not the real practice, because we all make the perspective or the frequency of patients treated with these life-saving drugs is far less than we should be. So I think we need to stop to seeing this nephroprospective or nephroprotective approach and try to address these patients with the drugs that they need. And of course, they are SGLT2 inhibitors, GLP-1 receptor agonists, and MRAs. Especially, we all know that finerenone is coming. It has a very safety profile that reduces the risk of hyperkalemia, which is a very feared side effect of these drugs, especially in the cardiorenal patients. So I think the future is sweet. I think we have drugs that we maybe will feel comfortable with using this kind of medications in high-risk patients. From my perspective, I usually, depend on the profile of the patient. I prioritize one or another. Maybe if I'm I'm a heart failure specialist, so my patients all the time have signs of fluid overload. So in this kind of situation, SGLT2 inhibitors are probably the first drug to initiate if this is the profile of that kind of this particular patients. Maybe if we are dealing with the obese phenotype of HFpEF, we all have now have evidence of efficacy of this kind of therapies also in HFpEF population without diabetes. This is the results from the STEP-HFpEF trial that had just been published in the last ESC Congress in August. And also we have all the beneficial effects of MRAs in the whole spectrum of type 2 diabetes. We know that these kind of drugs reduce the burden of heart failure readmissions, and currently is an ongoing trial specifically addressing the benefit of finerenone in the HFpEF population without or with diabetes. So I think, probably in the next few years, probably these three drugs are going to be the mainstay for the treatment of cardiorenal patients.
So, Professor Caramori, Luiza, you've been using finerenone and you've been using GLP-1 receptor agonists and SGLT2 inhibitors for a long time, because everyone knows that from the beginning it was like a glucose control GLP-1 receptor agonists and SGLT2 inhibitors. They were for glucose control, and now finerenone is very useful, and you are using that in the United States. Not all the European Union patients got that, but in the United States been already in use. So we would love to know, what are your feelings about these combinations, and if you've seen like a very, very good results in your patients at this time?
Yeah, I think I agree with Rafael that this is a very important point, and we tend, at least we who work in academia, to be very data-driven, right? So we are learning, I think, from the heart failure groups and the treatments, as you alluded to earlier, of starting these drugs sometimes all together, and there are studies that even showing heart failure that you can start then in a lower dose altogether in a very safe manner, and then you can raise the dose. So that's not what we usually do, right? So we usually, because perhaps the lack of data in the population that we manage, we select the agent that we start, and we start the patient on that agent, depend again on the patient profile, maybe the SGLT2 inhibitor. If the patient has CKD, has type 2 diabetes, is already on an ACE or an ARB, my next drug is going to be a SGLT2 inhibitor if the patient does not have any contraindications for that agent. And now we can use it to GFRs as low as 25 to start, right? With the understanding that we don't stop these drugs if the GFR drops. So we still continue these patients on these agents because of their cardiorenal protection benefit. However, lower the GFR is, less of this glucose lowering effect you're going to have with these agents. So if I placed my patients on a SGLT2 inhibitor, they are already on an ACE or on an ARB, and they are still hyperglycemic, then my second choice probably is going to be a GLP-1 array, because the non-steroid MRA will not impact my blood sugar. However, if blood sugars are fine and the patient still has some residual proteinuria or microalbuminuria, that will be my next drug of choice, will be the non-steroid MRA. So it really depends on the profile and what happens over time and how we assess and reassess the risk in these patients, because it's not only about the initial risk. We need to see what happens with the interventions, if we are reaching the goals that we want with that therapy or not, and keep adjusting. I think that what will happen, and I heard when Rafael said that the future is sweet, I think that we will learn how to use these drugs in association, because we have trials looking at that, and they will tell us if we can start them together or not. At least type 2 diabetes, we have those trials ongoing, right? Is it safe to do that or not? And is it beneficial to the patient or not? So I think that those are very important questions that we will have answered soon. One big limitation is costs. Sometimes the patient will tell you, I cannot afford all these drugs. And that forces you to make changes and choices that perhaps ideally we should not be making, right? Because we think that they could benefit from all these agents many times together, but sometimes we just cannot offer that because it's not a viable option, financially speaking, for the patient. So that's a big barrier that I think we will talk a little bit more later today as part of this panel. But lots of good drugs. If we go back to the 1990s, we had ACE and ARBs, and that was it, right? And if I go even further back, because I'm older than many of you, we would not even accept the patients with diabetes in dialysis. If you have diabetes, you could not be on dialysis. You are not accepted to enter dialysis, so these people would die. So things, of course, have changed a lot over the years. Now we are blessed with all these new agents and perhaps new more to come that are on the pipeline. So we have all this to offer, but we should be able to deliver that to our patients. So I think that there are still some barriers that we needed to overcome on that.
We will go back to this matter of money and cost in the last part of the panel, but this is a very important issue. Sometimes in most countries, not all countries, but most of them. So I would like to know if Jolanta has something more to add in this pharmacotherapy. And there's one question that addressed me and some other people in this webinar today. It was about frailty and what to use and how to use this kind of medications in frailty population, because as nephrologists, we've got a lot of people over 80, over 85, and there are not that many clinical trials in very old population, but there are people that are over 80, 75, 80, 85, even 90 years old that are very good indeed. And there are some others that are quite frail. So what are your choices? Do you use scales? Do you use some sort of scales for measuring? And do you use them for choosing the right medications or the pharmacotherapy or not?
Luiza, I cannot agree more concerning the diabetes treatment and possibilities to offer the renal replacement therapy. There were some commissions of life and death, and for young nephrologists, it was a disaster to have an overnight shift and having not possibility to start dialysis treatment. But fortunately, it's over. It belongs to the last century. We have a new century. And right now we have all the, possibilities. But as you told, there is also some obstacles. Let's put in this way, challenges and opportunities. We have a challenge. We have new drugs. And however, we have some limitations and some constraints concerning cost and reimbursement. But coming to one point, whether we should start all drugs together or sequentially. In comparison with cardiologists, I have my long track with collaboration. Nephrologists, I would tell, as Beatriz said, are much more conservative, because we have, I would say, much sicker patients. Because, and this is another one side of the story when the cardiologists recommend some drugs because they're good for heart. The general meaning and appreciation is it's so important because my cardiologist told me that. Cardiologist in the general, I would say, perspective is much more important doctor than the nephrologist. Because, well, cardiologist still is hot and sexy, that's true. So that's why the career of SGLT2 starts first off with cardiology, and then nephrologist followed. The one problem is that as we have much sicker patients with more advanced kidney failure or CKD, the later stages. So that's why I cannot say much more reluctant or hesitant, but that's why we try to titrate the new drugs. Because first of all, generally, we do have patients on RAS blockade, and this particular first drop in the GFR is far away because the patient's on a long-term RAS inhibition. But concerning the introduction of like two drugs together, I mean SGLT2 and MRAs, if it's a patient with advanced stages of CKD, I would start with one and after a while start with a second one, just to avoid adding two drugs together, knowing of having the hemodynamic effect. So, well, that's my pragmatic approach.
Can I add one thing, Jolanta, to your comment, because I think that's quite important when we are talking about advanced CKD. Of course, the patients with more severe chronic kidney disease, lower GFRs, are the ones at the higher risk for hyperkalemia. So yes, we may have some, based on the data we have available, right, the association of SGLT2 inhibitors with non-steroidal MRAs may actually reduce this risk of hyperkalemia. So, of course, we should be cautious and etc., but we should also think like, can we minimize this risk and still give benefit to the patients? So absolutely. I think that's what we are going to be learning, right? A lot with this use of these new agents. So many of them acting, they do act in different pathways, but they may actually have a beneficial effect in terms of reducing unwanted adverse effects of the other agents. So that, I think that's quite interesting. And I was just going to comment one thing on frailty when I think about the GLP-1RA, that I get a little bit concerned, because even though it's a drug that we can use in advanced stages of disease and works very well still in terms of blood sugar control, it's a great drug, we do see people losing too much weight. And there is such a thing as losing too much weight, I think, when they have advanced disease and they are sicker. And they not only lose fat mass, they lose muscle mass. And that goes back to what we discussed early on when I was talking about the foundation and having exercise, and Dr. Malyszko addressed that as well. So we needed to be careful there, because there is one thing as too much of a good thing, let's say. We just need to be careful with that population.
And honestly, Luiza, if I may add a little bit, I guess in comparison with other specialists, we are I would say not so afraid of hyperkalemia. We are used to hyperkalemia like close to 5, even 5.5, when other specialties are, well, trying to figure out what to do, and it's life-threatening. For patients with advanced stages of a CKD, they are much more adapted to the higher potassium levels. However, what we've learned during this many years of our clinical experience, that at first, we need to look at the diet. This is one point. And the second one of the concomitant offensive drugs. I mean, mainly non-steroidal anti-inflammatory drugs. They are prescribed over the counter. The patients are even not aware that the drug have the hemodynamic effect on the kidneys. They might cause hyperkalemia, etc. And also what I did learn as well, when patients, of course, vast majority of our patients are hypertensive. And as a doctors, we do advise them to restrict salt, because, well, we know that we eat too much salt, and that's why our diuretics, they does not work perfectly well, etc., etc. However, quite a lot of patients, they are going to the pharmacy and asking for special salts because they were advised to get rid of sodium. And often they are offered potassium salts as a spices. So there is a matter of spice as well. There is also a matter, what I did learn, of the supplements. Because, well, for quite a lot of patients, pills are one side, but some of them, they are also keen to diet supplements. And in vast majority of diet supplements, they are rich in potassium. So if you accumulate everything, this is the net effect is hyperkalemia. But in general, it's not I would say majority related to the basic drugs, I mean RAS blockade or MRAs, non-steroidal MRAs, but to the accumulation of other factors. So that's why I would say the key issue is education.
I can't agree more. And I think that you touched various points here that are quite important. One, talk to patients about diet, as you mentioned earlier, very broadly, but also very specific when there is hyperkalemia and other things that we need to address. So not only about the health lifestyle, but some of the concerns that we have. The non-steroid anti-inflammatories, I think that are very, very important. And I think that's a job for all of us. So I talk to my patients about preventing AKI, avoiding these agents. And I'm a diabetologist, right? But I talk to them about it. Many of my patients have CKD because that's what I do. But I talk to them about it. I don't wait for the nephrologist, have that conversation with them. So I think that's our job to do a lot of that. And if all of us do that, I think that it's much more beneficial to the patient. The other point I think that we needed to be considering here is that earlier we are saying that many of these patients that should be on ACEs and ARBs are not on them. And many times what happened is that the patient had a single episode of hyperkalemia when they are in the hospital doing whatever, or they had a CT scan or something, or they, imaging that had contrast, something happened, they had some hyperkalemia, they got dehydrated, and then drugs never started again. So that's another conversation that we need to have with our patients and educate patients and colleagues on that regard. So even if it's something is temporarily discontinued, does not mean that the patient can never go back to that medication again. And many times, it's listed on the patient's chart as allergy. And we're like, did you have an allergic reaction? And usually, no, they didn't have angioedema or anything like that. They have one episode of hyperkalemia, and the drug is never back on their list of agents that can be used. So many important points for us to discuss, and I really appreciate.
Just to contextualize the point of frailty, I think we should not confuse a frail patient with a sarcopenic patient because they are different. And we have plenty of consistent data showing that SGLT2 inhibitors, for example, works very, very well, regardless of the frailty scale. So I think these are different things. And in practice, we should use a more objective measures of sarcopenia, which identify the patient which is maybe in a more advanced disease, and maybe these patients may not benefit in the same way of this kind of drugs, but because of the disease they have, and not because of the drug is not effective. So I think this is an important point to contextualize.
So I think that's what you mentioned is certainly key there. But the thought that I brought up on sarcopenia was more in regards to GLP-1 arrays, when these patients have this drastic weight loss and they do lose a significant muscle mass. Actually, we have programs where we start every patient that we are starting on GLP-1 array, we try to connect them with our exercise physiologists for them to start an exercise program. Yeah. And our group are looking into that as a way of preventing some of the sarcopenia that happens. So I think that's more of a concern with GLP-1 array and the dual agonists that are out there, and now we're going to have a triple agonist. So I think it's a bigger, perhaps, concern on that area. But you're right, they are not synonymous, sarcopenia and frailty.
So this must be one of the challenges, how to manage this kind of patients, how to manage sarcopenia, or how to manage patients with these treatments. So what are the challenges for you? What are the challenges addressing or assessing patients with chronic kidney disease and all these comorbidities? And I would love to know about this with you. We are going to start with Rafa. How do you address all these patients? Do you address sarcopenia in your population or not?
No, we do not, and that's because I think the major problem with this population is that there are a lot of patients with this combined cardio-renal metabolic disease burden. So it's difficult to have a special program to a close follow-up and addressing all the comorbidity burden and all the side effects related with the medication. So I think one of the major challenges that we have is the organizational point of view. We need to try to work together and try to maybe the nephrologist can see the patient after the cardiologist see it, and also the endocrinologist be in the same plan of the treatment of these patients. So I think this is one of the major issues, and also the embarrassment, because these all are expensive drugs, and you were saying that before concerning GLP-1 agonist. The price is extremely high. So given that 60% of patients with heart failure are overweight, how can we in a public system like ours, like in Spain, are going to support these drugs? It's not possible to do that. I think we need to try to identify the patient who benefit most, try to select specific burden of patients that maybe are going to get more benefit from these programs.
So how to do that? Professor Caramori, how to do that? How to address these patients that are going to be more benefit from that?
Yeah, I think that when we do the assessment for these patients, I think that we all do some risk stratification and we calculate their risks of progression, not only in terms of progression to more advanced stages of kidney disease, but also for other cardiovascular disease risks. Some have already had cardiovascular events, so that have proven to you that they are high risk, but others are at very high risk and have not yet had an event. So I agree that sometimes we needed to be prioritized. Our system is slightly different. We are not in a public system. There is Medicare, Medicaid, but that often does not supply many of the agents that we need, and many patients have additional insurance. But even though with all the additional insurance that people may have, and they are quite expensive insurances for the population to pay for, many times the agents are not covered, they are not authorized by the agent. So it is challenging to give what we think that the patients would benefit from. So we don't, because we are not in a public system, we don't necessarily select, I need to give it to you because I don't have it for everybody. So I think that's what I'm trying to say. We can have a broader population who will benefit these agents. We still go back to the basics many times, that is, diet and exercise, because we can, if you offer these drugs to 60% of the heart failure population, as was mentioned earlier, you also need to think that these agents that are allowing you to lose weight, they need to be used chronically. You stop, you regain that weight. So it's not an infection that you treat and hopefully you are cured of, right? You need to continue on these agents. So you stop, you are going to regain the weight. So I think that all this education that goes along and all these lifestyle changes are of great value for this population, because that you can apply to everyone. Depends on yours taking the time, sitting with the patients and discuss with them the importance of that, and the patient adopting this information and these measures that really depending a lot on people to do that. So we often get families involved, we get communities involved, because that's a way of helping these changes to occur. But if you are going to go with medication for everyone with a pill, like we discussed, everyone wants a pill. And we didn't even address lipids, right? Because lipids is other big thing here. People have significant dyslipidemia, right? That goes along with the obesity, goes along with the CKD, goes along with the diabetes. So those are all things that we can address in these patients. So of course, patients that we see that are in the tip of flipping, we are more aggressive, I think, and we see them more often, and we have less inertia in making these changes in medication, adding new drugs and adjusting doses. But we, at least in my perspective, we really try to offer this to everyone, going from prevention to treatment, if that's what the drug has been shown to be of benefit to the patients. Again, on top of the foundation of lifestyle change. So, yeah, long
Very
answer,
important.
but it's a big problem.
It is. It is. Jolanta, your comment?
I would say that my first comment is that the toughest part is the education, in particularly in patients with many risk factors and not willing to change their behavior. This is also the matter of obesity. This is also the matter of unhealthy lifestyle. For me, this is I would say the toughest part, I would say time consuming, and sometimes the success is, let's put it this way, suboptimal, and both of us, patients are not happy, we are not happy. Concerning the rest this is another one problem is that we're still facing the legacy of the pandemic when quite a lot of people stayed at home and exercising the unhealthy lifestyle. So that's why let's say in our department, we did see quite a lot of people with advanced stages of a CKD, with advanced malignancy. I'm sure it will take time to get rid of this. I would say, I cannot say leftovers from the pandemic time, but still, this is one point. The second point is that there is an early detection of disorders, like early detection of a CKD, early detection of diabetes, not when the complications are present, but far before. So this is one point. A second one is trying to introduce as early as possible all the preventive measures, and goes together with the discussion concerning the pharmacotherapy. I would say that in every system, both in public and in private, but in general in public system, we do not have enough time to spend like half an hour for discussion on 1 hour with patients and the family. It's sometimes easier in a non-public system. And this is like the Achilles heel for our mutual relations. Sometimes also there is a matter how to convince not only the patient, but the closer relatives and the family to change the lifestyle and also to be adherent to treatment, to pharmacotherapy. So for me, this I cannot see this unmet need, but we are facing these problems for many years, and also with all the brand new systems, with computerization, with all this data available, it appears to me as a experienced or mature doctor that we don't have so much time for communication, for education, and really for trying to assess our work and our success in treatment of, I would say, first of all, chronic diseases.
So thank you. And this is another question about this combination with different doctors, with the mature ones and with another professionals. And do we talk with other specialties? Do we have an interaction, a real interaction with other specialties treating these challenges in people in this population, in CKD population? So here I would love to Rafa to talk about this interaction you already have in your cardiorenal unit in Valencia, because this is a very good example, and then a word from all of you about that.
Yes, of course. I think this is really important because these are really high risk patient, high risk population. So we have in this moment from 3 years ago a cardiorenal unit in which a nephrologist and I, a cardiologist, work together. We see the patient together in the same clinic. So the patient is coming to us and is not going to first to the cardiologist and after to the nephrologist. The cardiologist do that, prescribe that kind of treatment, and then the nephrologist withdraw the treatment that the cardiologist just prescribed 3 days ago, and the patient is in the center of that. This is the real life. This is happen every day in many hospitals. So I think we need to see this disease as a whole, as a one disease in which we are sharing the patient with other specialties, with nephrologists, and maybe endocrinologists, internal medicine. Is part of our work to try to collaborate together to make these things better. In our department, we have right now more than 300 patients included in this program. Right now, we have some data that maybe we can share, showing how is our population, how is the patient that we see in these clinics. And I'm going to share with you some of the data. I have to excuse myself because this presentation was not prepared for this session. So the slides are in Spanish, but I'm going to translate it to you. These are the importance of these units and how are the challenges to maintain and enhance them. First of all, we need to say that why are these clinics important? So these are data from our centers. From our center, as you can see here, in patients admitted because of acute heart failure, almost 32% of them have advanced kidney disease. And we also have recently published data from the CardioREN registry, which is more than 1,000 patients with chronic heart failure in heart failure units in Spain. And as you can see here, the burden of chronic kidney disease is really high. As you can see here, more than 60% of patients with heart failure have at least less than 60 GFR less than 60. It's really difficult to handle these patients with our perspective. So we are dealing with a rest treatment paradox in which patients with advanced chronic kidney disease and heart failure are treated with the less modifying treatment. And you can see here, patients with GFR between 30 and 44, quadruple therapy, only 1/3 of them received it. And despite this, not contraindication for that, according to our guidelines. So it's the same patient from different perspective. Here is the cardiologist, the same patient, a lot of visits, and you have the nephrologist, a lot of visits. It's easiest to see the patient together and maybe discuss our treatment together. And that's the reason why we think that building up a cardiorenal clinic is really important and may help us to improve the outcomes in this population. These are from the recent data that I'm going to show you. First of all, this is a really comorbid population. As you can see here, the Charlson index is 5. The median Charlson index is 5. And as you can see here, in a median follow-up 120 days, we are seeing almost 600 visits in 120 days of median follow-up. Patients may have more than 10 visits with both specialties. This is the baseline characteristics of the population. Very old population. The majority of them are males. Most of them have a previous admission because of heart failure, half have HFpEF, GFR 25, patients with really advanced kidney disease, with congestion, with really high natriuretic peptide, so really high-risk population. And despite of this shared decision-making and shared treatment optimization, the mortality at 1 year still is 25%. And if we see the causes of death, you can see here that these patients, half of them died because of non-cardiovascular causes, because of the high comorbidity burden. And also, if you see the morbidity, 83 readmissions in 59 patients. That means that patient had more than one readmission in 1 year follow-up. And the causes of readmission are mainly non-cardiovascular related. Infections, hemorrhage, it's really difficult to deal with this population. And we need to measure outcomes. We need to measure what we do, because we may feel that we do things right, but do we really do things right? Or it's just a feeling? In this population, as you can see here, if we work together, we can achieve triple therapy, 50% of triple therapy in patients with less than 50% of rejection fraction. PTH, phosphorus, calcium, all in range, hemoglobin, potassium, iron metabolism, if we work together, we can achieve these goals. If we work in parallel, maybe it's more difficult to get these results.
That's been a very important view and a very important point, because we were talking about like this special comorbidities and this therapeutic inertia that we already have, because we work in parallel. Maybe there will be like this inertia, like this patient was admitted and then the patient was discharged without whatever GLP-1, SGLT2 inhibitor, or ARBs or ACE inhibitors or whatever. But then if the patient's seeing together, maybe we can have much better results, as Rafael was telling us. So I would love a final point from all of you about this thing of working together, and if there's still something that we haven't done and we should do and we should improve for better addressing and assessing and profiling and treating our patients with CKD and all these comorbidities. So Luiza?
Yeah, so I think that not all centers, of course, but there are centers in the US also starting to do cardiorenal metabolic clinics. So we include the metabolic on that. And that it's so interesting because I think that it started not so much from knowing that many of the pathogenesis is uncommon, because that we know for years, was actually moved by the knowing that the drugs can impact all these conditions. So I think that was a big driver for these clinics starting and growing. What's quite interesting if we think about it, the way that actually happened. And there is some conversation too about, and that addresses exactly your question, Beatriz, about other conditions that we many times don't assess. These patients often have liver disease. They have NAFL, they have NASH, that if we detect early on and we manage it, can be reversible. If we let it progress, they are going to develop cirrhosis, right? And that's going to increase the risk of admissions, infections, and etc. So I think that that's still not properly addressed in our patients. And even though some of the agents that we use may be of benefit for this condition, so we may be addressing directly, but we actually don't assess properly in many of the patients. And the other aspect is that we mentioned, so if I come from the endocrinologist, from the diabetologist perspective, how often do we have these patients screened for heart failure, even with simple questions? Many times does not happen, right? Atrial fibrillation, usually these patients are checking blood pressure and their heart rate in a machine. that may not detect heart failure. I have the luxury of taking the time with my patients that we are comment about earlier. So I do have that luxury. So I can take half an hour, 40 minutes to talk to them about their condition, but also to examine them and do a proper physical examination. So yeah, I hold them and listen to their hearts. But sometimes if you think about where these patients are, and the vast majority of these patients with all these comorbidities are initially in a primary care clinician clinic where they see patients every 15 minutes. So how can we address all that? So there's a lot of challenges, as we mentioned earlier, lots of opportunities. We can do better. We have the tools to do better, but we certainly need a big support from the system. So what we are not addressing are some of these comorbidities that I think we could address, and certainly offer our patients these medications and provide the next step so that they can actually take them. Now,
Jolanta.
Coming to, I cannot say nephrologist point of view, but holistic point of view, the patients are the only one and have multiple comorbidities or multimorbidities. So that's why we need to think about the patient as a human being with different disabilities, disorders, problems, and how can we address them. The crucial point is education and time devoted to the conversation of the patient, listen and trying to react. And another one point is that, as Luiza mentioned, the cardio-renal metabolic clinics, to have the specialists together, because with the basic stuff, I would tell that the primary care physicians are really very good specialists, and they can address, I would say, the basic things. With more complicated, they have us, I mean, they have specialists, they have the second level, and they can have our advice, recommendation, help, even the more thorough diagnostics procedure and prescriptions, and also the possibility to consult either as teleconsults or mails or letters whatsoever. So I think there is also kind of prioritization. Less complicated patients should be followed by primary care physicians, because to save some time, efforts, slots for more complicated patients, to offer them our experience, our knowledge, our time for the best outcomes. And it's like a combination of, I would say, education, prophylaxis, preventive measures, and non-pharmacological and pharmacological treatment. And if all these, I would say, parts work together, we'll have the best possible outcomes. Otherwise, we are fully aware that we need to work on it.
We just have 1 minute left. And Rafa, do you have a final comment?
Yes, absolutely. I think it's also, the most important thing is work together. That's my final word.
So we have to work together because the patient's only one, and we have to give the patient the best we have. So thank you very much for joining us today. We hope you enjoy as we did, and thanks. Enjoy the evening.
Thank you.
thank you.
Thank you.
Thanks to you.